Hey everyone, welcome to Clinical Unfiltered, where we bring you dentistry from the brain and the heart. And today we're going to start kind of like a two, three-part series on talking about wisdom teeth, Wizzies with Dr. V, oral surgeon. And so I'm going to let you kick it off. I mean, the way I think about it, as a periodontist, I mean, can I do wisdom teeth? Yes. Do I love doing wisdom teeth? No. Um, but the reasons why I'm hoping to like incite and or point out the reasons that irk me about doing wisdom teeth. So maybe you could flip me on my head and say, okay, no, it's a fun thing to do. But one of the first things I do, when I see a patient coming in, I look at the pano. Obviously, how does your like initial visit for the wisdom teeth?
Absolutely. So, hi everyone. Nice to meet y'all. Actually, taking out wisdom teeth is my favorite thing. The reason I love it is because it's very predictable if you have a stepwise approach to them. So, in the consultation, the first thing I do is I greet the patient. I ask them if they've had any experience with any other oral surgeons or any wisdom tooth surgery period. Sometimes their brother, their sisters have been through it. And so they might actually have a lot more knowledge than you think. Next thing I do
Okay.
is I examine the patient. I touch them, I get to know them so they trust me. So that everything I talk about after, they're listening to me. Then I go to the
But most
radiograph.
of these patients are coming in knowing they want wisdom teeth done. They're like,
Yes, absolutely.
yeah, like
Most of
that's been the
them,
call. And in pain or not in pain most of the time.
so a little bit of both, but most of them don't know why they're getting their wisdom teeth out. They were just
Oh,
told
okay.
they got their braces off and now it's time to get these teeth out. They don't understand the risks associated to second molar impactions and distal caries, things of that nature. Some of them are in pain, some of them are experiencing some low grade or high grade pericoronitis depending on the age. Some of them they're not even erupted.
So how often do you think you're actually going through that conversation of like, this is why you need them out?
I tell my patients every single time why they need it out. I go through risks, benefits,
Okay. So
adverse
even if they're like,
outcomes.
ah, crap, you're like,
Absolutely.
this is why you need your wisdom teeth taken out.
Absolutely,
Gotcha.
because a lot
Yeah.
of people don't understand that the pain is coming from the wisdom tooth. They might think it's
Okay.
related to something else because they can't see
Gotcha.
the tooth in their mouth most of the time. So you need to explain something that's hidden, something they can't see.
Gotcha. Okay. So I mean, I'm assuming even when they have pain, it's like one wisdom tooth, and then you're like looking at it, it's like, hey, there's
This
three
can
other
happen
ones.
to the other
Yeah.
one on the
Yeah.
other
Gotcha.
side. Let's take all four of them out before you're in pain. So it's always really important to address the patient first, gain their trust. Then I go to my radiographic exam. Then I talk about different forms of anesthesia.
In that consult realm, well, like, I mean, you've obviously got it down. You're doing this on the reg.
6 minutes.
I mean, your procedure. I'm talking about the examination
Yeah,
portion. Like,
15
you're
minutes for the
walking
procedure.
in. Okay, gotcha. It's longer to examine than actually do the procedure. You're walking in. Are you like? Because I'm assuming you've seen the pano. Do you do pano or cone beams out the gate?
I do panos. Most of them already have cone beads attached to them just based off the type of x-ray that we're taking.
Okay, gotcha. Okay, so when they're so you've saw the X-ray. You're coming in. Are you immediately addressing like what's your immediate spiel? Like, give me that summarized. Like, how do you win the patient over in those wisdom teeth situations?
Oh, well, honey, I don't talk about wisdom teeth to win my patient over. I
Right.
compliment them.
Yeah. Okay.
So I walk
Gotcha.
in, I shake everyone's hands, I
Yeah.
compliment on something that I see, maybe their shirt, their hair, their shoes. I always pay them a compliment. Find something relatable. Maybe they have, for you, University of Florida on their shirt. So you find something relatable, gain their trust, and yeah. Then I talk about wisdom teeth, and then they already trust me. So everything I share with them, they, revere or they hear as expert knowledge, which is what you
When
want
I
to do.
Okay, let's you get the patient who's like, okay, the guy, a lot of people listen to this probably listen to Dr. Vale to talk about clear aligners. You got a patient with clear aligners that's got, that's been sent saying, hey, like I've been told maybe I need to have my wisdom teeth taken out, and maybe they don't even believe it. Like, like they're not really bothering me. I'm about to go through clear aligners. Like, what's the conversation there? Especially they've been referred to you to have them take it out. I'm assuming you're like, okay, we probably need to go through the process of taking it out. How do you
Yeah.
like win them in those situations?
So I talk about all of the risks associated with retaining their wisdom teeth. So for instance, if they're a younger patient, we'll talk
And
about
like
like
use those layman terms. I kind of want to know like what those keywords you're doing that's
oh,
like
absolutely.
triggering the patient to win them.
Yeah, so the first thing, especially if it's a younger patient, which most of them, are, the majority of them are, the first thing I talk to is about the impact of an impacted tooth on the inferior alveolar nerve. So I'll point out that the apex of the third molar, if they're under the appropriate age, is still open, how it looks different than the other fully formed teeth. And I talk about the nerve, and I talk about, since the tooth can't grow up into the position, those roots will grow down and wrap around the nerve. And then I explain that the majority of patients that experience symptoms like permanent anesthesia of the inferior alveolar nerve are because they address their wisdom teeth issues when they're a lot older. So that's the first way I win younger patients over. The way that I win all my patients over is usually about talking about the impact that it has on the distal of the second molar. So that's the biggest, most important thing, is you tell them that if they don't address this tooth, then it'll result in cavities in areas that the dentist can't put fillings, and then we'll end up having to take both of these teeth out. And usually they're like, oh no, man, just take one tooth out. I don't want two teeth
Right,
out.
right, right. Yeah.
So depending on the age of the patient, those are usually the first two things. And with either of those things, usually patients are like, oh no, let's do this now. We want to address this immediately.
Gotcha, gotcha. I mean, we'll have another talk about sedation and well, deep sedation and moderate sedation. But I know you go through that route with them. So like, I get most of my wisdom teeth patients like referred to me, like adults. They've had perio or they've got cavity. They're doing some kind of reconstructive, dental procedures, and they need their wisdom teeth are involved and are going to come out, but they're fully rooted sometimes. Like even with like 50% bone loss, maybe they're fully rooted now wrapped without around the nerve. I mean, I don't get the ones that are in buds, but I'm assuming those are easier. You're getting those and you're like, woohoo, compared to the adults with the roots that are going all the way to the nerve.
So, first of all, I never say a tooth is easy. As soon as you say a
Okay.
tooth is easy, it'll kick you in the ass. Just have
Yeah.
the worst tooth I've ever taken out is actually a baby tooth. Okay, they all have their own difficulties. For instance, the ones that are not fully formed, like less than a quarter root formed, those ones are we actually call spinners, because it doesn't matter how many times you section them, the tooth will just spin around the burr. So you try and get this cross section, but
Oh
sometimes
wow.
the erupted teeth are
So while you're
ankylosed.
while you're trying to section it
Oh, absolutely.
within
Yep,
that
it'll
that
just
bud, it's
spin in its
spinning
little hole.
around your burr. Oh my
Yep.
God.
Yeah, so and that's why you don't take wisdom teeth out on patients that are very young that have just initial tooth buds, because you actually end up removing more bone and causing more harm to the patient. So the ideal
Gotcha.
age, depending on the height and weight of the person, is usually around 13, 14, 15 years old, depending male, female.
Gotcha. Gotcha. Okay, so that is the ideal age
Yeah.
range.
So they're all equally hard.
I gotcha. Okay, good to know. Good to know. So let's approach that age range first. That 13 to 16-year-old patient. I'm assuming there's a little pushback. Now you've gotten the patient in the chair. Procedurally, how do you approach most of these cases? And then I'm going to hit you with like, what was the hardest one?
So procedurally, you're saying intra-op? Like, what's my flow?
Introp. Yeah,
Yeah.
yeah. What's your flow?
Well, my flow is
Typical surgeon's flow.
always 32, number one, number 17, number 16. I always take out the bottom tooth first because I don't like the upper tooth bleeding into my surgical field. So, always, usually, too, the
Okay.
bottom teeth are the more difficult ones. So,
Funny. I
if they
normally
can
do the
get through,
top. I just had a habit. Like it's like a periodontal habit. I treat the top, then I come to the bottom. But interesting. Yeah.
but the top
Yeah.
bleeds into your surgical site.
Interesting.
So
Yeah.
then you're chasing two bloodbaths.
See, I'm taking so long that it's coagulated.
Fair enough.
Yeah.
Like I said, my entire surgery is about 15 minutes.
Yeah.
First of all, I always talk to the patient, first of all, as I'm getting them numb, getting comfortable, ensuring there's profound anesthesia or profound sedation. That's the first most important thing, because if you start cutting on a patient that is not sedated or anesthetized, you will lose their trust and the rest of the procedure will be a nightmare. So,
Blocking Lido.
so I always block my IANs bilaterally with a carpule of marking. So I actually, I block my posterior superior alveolars, my number one, with a full carpule of lidocaine. Then I do my right IAN block with a full carpule of marcaine. I use a carpule of septo to then infiltrate around the tooth, which kind of, I have a technique where I don't actually anesthetize the lingual nerve. I kind of just go and they call it fluid dissection. So I hydro dissect over the third molar so that it kind of goes over the mylohyoid and into that
Oh, okay.
lingual nerve.
Gotcha. Just
And
almost
then
like right on top, press, let the
exactly.
pressure
Yep.
expand into that. Okay, gotcha.
And so
Interesting.
then you
Okay.
don't run the risk of injuring the nerve directly with your anesthetic needle, because that's the number one
Gotcha.
reason for lingual nerve injuries is an anesthetic needle. So then I
Okay.
hydro
Not so
dissect
much breaking the plate, but actually injecting
all.
and wrecking.
Well, if you break the plate, you have a tendency to push the entire nerve like
Gotcha.
further away, but it remains attached to the periosteum. Whereas if you infiltrate the nerve with a needle, you're damaging the epineurium. And so that's what
Gotcha.
causes the actual paresthesia or anesthesia.
with septicane.
Yes, exactly. And septicane, most importantly, because it's the most toxic.
Gotcha.
So then I do the same thing on the other side. And then, like I said, I make my incision, I reflect my
Incision.
tissue, I trough.
Talk
I always
incision.
try and use my handpiece once. So I do as many cuts as I need before I put it down. Then I love my 77R. So I use my 77R. If I need some criers, go ahead with that. I irrigate, irrigate, irrigate. That is
I'm
the
gonna bring you
number
back
one
to
thing. Yeah.
incision design.
Oh, I thought we weren't. Okay, let's do it.
Yeah, yeah,
Incision
yeah. I
design.
want to know incision design. How are
All
you
right.
cutting?
My incision design is always a modified hockey stick at the basically the middle occlusal plane of the second molar. So I
Okay,
never go lingual. I never pass the lingual cusp. I never make my incision lingual to the middle of the second molar. I make a modified distal hockey stick. I reflect the distal the distal aspect of like the second molar into my hockey stick, full periosteal dissection. I personally go to the edge of the ramus to allow my retractor to sit there more
gotcha.
comfortably because if your burr nicks the periosteum, there's lots of vessels.
Whenever I go short, bringing it up the ramus, I feel like I'm eating it. I'm just like I can't see, I can't reflect, and I'm fat. Like 'cause at that point, I'm like I could be destroying tissue, and I'm just like I'm taking the burr. I'm like screw it. Now I'm cutting it with the burr, which I'm sure is going to be more comfortable afterwards.
Yeah, and that's
Yeah.
really the number one thing with surgery is access. If you can't see it, you can't chase it. You can't get it
Yeah,
out if you can't
I
see
do
what you're
think that
doing.
that with wisdom teeth and I mean besides the potential postoperative complications, I feel like a new doctor getting into wisdom teeth, I think access can be a little bit scary because you're used to being able to like clearly see everything, and now you're in like the dark crevices, corners of the jaw, where you aren't as used to bringing a blade to that area and feeling that because you're feeling most of the time if you're putting a blade, I think against the sulcus, you're running into bone quickly,
Hmm.
but as you head up that ramus you're not in there as quickly. So you're feeling like, where is my blade dropping into?
Exactly.
That fear
And that
can kind of, make
Absolutely, and that's
doctors
why
pull
it's
back a
always
little bit.
important, when I palpate for my IAN blocks, I'm palpating the anterior aspect of that ramus. And when I'm making my incision design, that's why I don't go too far lingual. Because if you go too far lingual for your crestal incision, when you make your hockey stick release, you'll end up into those medial tissues of the mandible. So if you make that hockey stick release kind of more lateral and follow the anterior aspect of the ramus, when you dissect subperiosteally, it lift up like an envelope flap and that whole thing will just peel up. And I don't usually dissect anterior to the second molar, just that distal, like that the distal aspect of it, I do reflect so it doesn't tear.
Gotcha. So it looks like you're not actually pushing too far back on the lingual
No,
flap. Like your lingual flap is pretty intact.
yes,
Are you even reflecting lingually, or are you
no,
just
I
like
do
it's
not.
just all
I
that
do not.
facial? I mean, I guess yeah. What are you trying to look back there?
There's nothing
Okay.
there. You're just going to
Yeah.
fall off to a dark ledge there.
Gotcha.
And
Good.
that way
Good.
too, also, if you don't reflect the lingual, if you do have a lingual plate fracture, which actually funny that we bring that up. I just had my first really severe lingual plate fracture of my career to the point where the submandibular gland came up from the actual apex of the extraction socket. And I was like, don't suction that. But if you do,
Oh.
yeah, it was a bad one. But it's okay. The patient's doing great. We managed it appropriately. It's a risk of surgery. If you're going to do surgery, you have to know how to manage your complications. And so I find that if you're
Absolutely.
not reflecting the lingual tissue, if you do have a lingual plate fracture, that bone fragment remains firmly adherent to the periosteum.
Oh,
And so then you
awesome.
don't have to take it out. You don't have to dissect it off the nerve. You can actually just leave it in, get good primary closure, put the patients on antibiotics, and you should get primary union of that fracture.
Gotcha. I feel like also it might, if you do start reflecting into that zone, if you're getting postoperative swelling, tissue may be looser there and another pathway to expand after the fact. So
Exactly.
if you've got that like, untouched, you know, no harm, no foul that way, like swell facially, not
Yes,
lingually.
exactly. Absolutely. You
um,
don't want swelling under the tongue.
gotcha. Okay. So you flapped and now you're saying, so I mean, you're throwing out numbers. I'm assuming those are the names of burrs.
So that was actually an elevator, but the
Oh,
burr that I
elevator.
like
Okay.
personally is a carbide 702 long. Really important that you know the length of your burr, because then if you know the length of your burr, if the whole cutting portion of your burr is fully submerged in bone, then you know how long it is, and so you know how far away you kind of are from the nerve based off whether you're in the occlusal middle
Oh,
or apical third of your extraction socket. So like if I'm in the
gotcha.
apical third of my extraction socket, I'm not digging my whole 702L into the bone. But if I'm in my occlusal third,
Gotcha.
I know that I can submerge my entire drill in there.
I
to
gotcha.
trough without
It's
affecting
it's a
the
it's a
neck.
length gauge. I mean, you're looking at your pano, measuring how far away you are from other anatomical structures, and
Exactly.
your bird's like, you're measuring that too, and you're
Exactly.
correlating the two. So
It's
you're
my
like,
probe.
okay, gotcha. Yeah, yeah, yeah. No, I know. Awesome. I love. You know what? They should mark those. Maybe like have a
They
10
should.
millimeter mark length. And it's like, okay, I know.
I
Like,
mean, but
oh,
even
okay,
then,
that
can you
soft
even
tissue I
really
just ran into is maybe the nerve.
yeah, but can you even
Yeah.
really see the markings on your implant drills? Come on now.
Some of them you can. If you got a good one, you
Yeah.
can.
I
Yeah.
do, by the way,
They
I
should
will
make them
say
rainbow colored. I
they
really
should
should
make
say.
them rainbow color.
Yeah.
I will say I believe in single use drills. So I
Okay.
only use a burr once. Number one is if you've ever had a burr head fracture deep in an extraction socket, you know how devastating it can be. The posterior aspect of the mouth is not a forgiving place for broken burrs. And number two, they're not super expensive. And then they're sharp, they don't dull. And if they're not dull, you don't create as much necrosis on the bone when you're cutting it. So you're cutting it with a sharp burr. They're like $10, guys. Just get a new burr.
That's a good point. I even buy like high quality birds, and I had one
I,
break recently in like a number 14 site in like the palatal socket, and it was kind of stuck.
mm-hmm.
And I was like, I'm gonna have to like trough out and actually have to like expose the sinus. It actually got really annoying. So having a fresh burr in
Yeah.
the deep dark corners of the mandible again,
I
that makes
actually
sense.
had to section a number 16 recently and only realized my burr tip was broken off because my assistant was cleaning or they kind of organized my table for me and they
Yeah.
moved my drill over and they were like, your burr head broke. It was luckily in the trap because I
Ah,
shoved that suction
gotcha. You were
into
like
the
unaware
sinus
of it. Yeah.
cavity
Yeah.
and irrigated the sinus cavity and we luckily got it out and confirmed that it was in the trap. But and that was my
Yeah.
last tooth. Number 16 is my last tooth. So that's after four
Gotcha.
teeth. It can easily break. So there's
Right.
no
Okay.
reason that you should be using these burrs on multiple patients. If you want to decrease your postoperative complications, that on top of irrigation are my two like pearls.
I can imagine running a burr 1-to-1 ratio on cortical bone in the posterior mandible can wear and
Yeah,
tear
twice as
on a
good.
long shank burr. That's the thing. These are long shank burrs, so they've got a
Long
weak
chains.
point. Yeah.
They're about
Um,
59 millimeters shaft length is what I use.
so your drilling pattern over an fully impacted lower wisdom tooth, how do you drill around it? Do you drill like
Mesial to distal, I trough. So my assistants and I kind of have a dance. So I recommend that you do everything the same way every single time. That way your assistants can predict your next move. And also that way, in case you forget to do something, they can remind you of it. So I dance the same dance. I go mesial to distal. I dig my trough and then I section buccal to lingual. I never go past the middle third if I'm sectioning buccal to lingual because you never want to
okay,
put your burr through the lingual
yeah.
aspect of the tooth. So I
Don't go all the
prefer
way through.
no, I prefer to make my osteotomy through the first two-thirds of the tooth and then I crack it with my elevator.
Okay, gotcha. What if you're
Yep.
not cracking it? I mean, you try and it's like, it's not
So you
it's
can
not
also just
breaking.
create a trough without sectioning and then elevate from the buccal aspect of the tooth as well. But you want to make sure your trough is wide and deep enough to be able to fit an elevator. And this isn't a crown prep.
Sometimes I've noticed when they are so measly angulated that they're kind of stuck underneath that, that second molar
Hmm.
in on the mandible. I mean, how are you? So, I mean, are you sectioning straight middle through, or you're doing that kind of partial section, like that cut through the crown, that angular cut?
You know, it all depends too. I actually, so full disclosure, I'm very transparent. I actually recently had a number 17 I was taking out and I didn't section it enough. And there was a huge cyst around it. So there was a lot of bone loss on number 18. And actually, number 18 popped right out. Because I
Okay,
didn't
there
section
you
my
go.
tooth enough because it was
Yeah,
exactly in that position. It was impacted kind of under, that
gotcha.
distal aspect of that second molar. So my recommendation is always to address the crown first. So sometimes when I can't see it, I'll just chop off that crown and however many pieces I need to, and then you'll be able to see the root canals. Okay, and then once you see the root canals, you'll be able to know where the furcation is, and then you can split those
Oh,
roots. So if you ever
okay.
get
Like
lost,
pulpotomy that thing to that
exactly.
point. It's like, okay, there's the furcation
Yep.
trunk.
So that's
Gotcha.
exactly what I'll do.
Interesting.
Yeah.
Gotcha. So rather than going for the furcation first,
Well,
is
sometimes
that
you
a
end up having to
strategy? Like
trough
break it
too
into
much.
half and then
Yeah. If you
break it
can,
and
I
do.
always try and adjust the crown first, get the crown off, assess the root scenario based off the anatomy of the pulps, and then section there and take the roots out in two pieces.
Gotcha. Okay. So crown's been sectioned. I mean, we're even talking about that. I feel like those are the most difficult. Now, granted, I know you said don't say any of them are easy, but as far as like level of complexity, I'm
I would actually
assuming
say
the more
distoangular is the hardest.
distoangular.
Yeah,
Okay.
because
Yeah.
it
Those
removes
are
a lot
rare
of that
though.
lingual bone. Yeah.
I'm assuming those are more rare though. You're not running into those too frequently. Distoangular,
Well,
unless
I
they're like
am because
you are. Yeah,
everyone else
you
is
are.
taking out the
Got,
easy ones.
gotcha. Gotcha. They're like a VC angler. How are you handling a distoangular comparatively?
It's another conversation for another day.
Gotcha. The distoangular wizzies, part four of
Yes. Yes.
wizzy.
Part four.
You really want to eat shit while you're working.
Yes. I'll make
Talk
sure to
about the
include a video.
Gotcha. Yeah, yeah, that'd be dope. And then, so okay, so yeah, I guess most people are going to be running into the mesioangular
Yes.
situations.
But also equally important to section the tooth properly because, like I experienced, you might even be able to elevate that second molar. If it's impacted under that distal cusp, you could potentially put enough force on it to lift out that second molar.
Gotcha. I mean, I'm assuming that's a good conversation to always have.
Yeah.
Mesioangular, talk about the second molar. Look, hey,
Yeah.
this is a unique situation. I mean, I'm assuming you have your own gist for how do you, what's the exact verbiage you're using to tell them to be aware of that in second molar so that when you pop out that second molar, they're like,
Well, I
okay,
just put it back
like
in the
she
socket
said.
and sutured it and followed the patient. It was fine.
Oh, okay, gotcha.
Yeah.
You re-implanted the
I
tooth.
reimplanted the tooth.
Wow, okay, gotcha.
Yeah.
Interesting.
And I packed this third molar site with lots of PRP.
Okay,
I injected
gotcha.
it around the second molar. I put some very
Interesting.
nice,
Oh
mattress
man.
sutures in there, wrapped the tooth around, and
So,
put the
so,
patient
so
on a
I,
liquid diet.
we're gonna have a segment where we just go through unique cases. Like we're gonna do that that anterior case that me and you
Hmm.
worked on together. I'm gonna go over that
Absolutely.
case. This would be a cool case to follow up on.
Yeah. Well, he
I feel
actually did
like
great. I actually
like
followed it for 2 months already. He did great. The
I'd be
tooth
like,
was
can you
fine, no
please coming
issues.
back for a year? Like
Yeah.
give
No,
him a
he was fine
Starbucks
in
kid
6
card to
weeks.
come back next year.
Yeah.
Like just to
But
see how it's doing. I want to know how it's doing in a
yeah,
year.
and I warned them about a root canal and everything. They were aware.
Yeah.
They were grateful. We told them, and I always tell patients that there always is risk of injury to the adjacent second molar. It's important that you warn your patients about possible complications that you could have in surgery, so that if you do have those complications, when you inform them that you had those complications in surgery, they're like, that's okay. You already told me about it. I'll see you
Yeah.
in 2 weeks.
And when it didn't, you're a hero. I mean, that's the biggest thing. Is like I feel
Exactly.
like when you're communicating a potential risk like that, like losing a secondary tooth when that is not the goal in that
Yes.
scenario. Um, it's you mention it as, hey, there is a risk here. Your tooth kind of came in, and that's why we're taking it out. Is because of the risk to this other tooth. But the goal here is obviously not to get it out, but it can happen. And when it doesn't, you're the hero. Which most of the time it doesn't. Any other tips and tricks on sectioning, or are you ready to move on kind of like to the elevation portion of it? Because I'm assuming you're sectioning prior to elevating.
Yeah, no, that was pretty much all I have on sectioning. Adjust the crown first, adjust the roots later, know the length of your burr, make sure it's wide
Gotcha.
enough to fit your elevator in.
So elevators, you threw out elevator numbers.
Yes, so I like a 77R. It's kind of like a back action. I just like the angle that I get in the third molar site because it's really far posterior, and so your straight elevator sometimes it's hard to get the right torque on it. So the 77R, that back action, it really just helps me kind of put that torque on it from where I'm standing.
Is that the only one you need? It's like that's your go-to, like one and done. Stick it in between the teeth. Stick it on the right of the tooth.
Yeah,
Never stick it on the lingual of the tooth, though, I'm assuming.
not unless you've done it a few times before
Okay,
and you know
gotcha,
what you're doing.
gotcha. So that mesial portion, I'm assuming, is where you're working the most.
Most of it,
You're not
yep.
going,
Or if
yeah.
you're sectioning, you want to start there, section off the distal half first, and then adjust the mesial portion because the mesial portion
Okay,
will then have a lot more room in
gotcha.
the socket. Yeah.
Gotcha. Distal out first if you're going through the
Yep.
furcation, then the mesial out.
Exactly.
Now cleaning it up. Now I'm assuming
Irrigate.
that's the next.
Irrigate.
Irrigate.
I irrigate with
With,
Paradex under the
with all
flap,
the
the whole
systems.
socket. A whole monojet syringe goes into each extraction socket.
Okay, gotcha. Curetting pretty thoroughly, or you?
I remove any follicular tissue and clean up the distal of the second molar, and curette that out. Make sure you don't have any loose bone fragments, things of that nature.
I have treated a decent amount of periodontal defects that have formed on the distal of second molars. And I always ask them, like, how did your wisdom teeth extraction go? And most of the time they'll be like, oh, it sucked. Like, it's just like, it was like it didn't heal properly, likely, and some granulation tissue. And then lo and behold, I mean, I'll find calculus on the back end. And for me, it's hard to say, was it there before the wisdom teeth extraction, or did it develop because there was maybe poor healing from the third molar site, and that's why they developed a pocket, then calculus formed on it? It's hard for me to pinpoint that. Normally, I can kind of guess if they had like I could tell poor oral hygiene. I'm like this is the third time they've come to the dentist in 50 years. They probably had calculus since they were like 10 years old,
Yeah.
and it didn't get cleaned. That's a very likely chance. Is there like a higher instance, like, oh, they got a bad mouth, like a dirty mouth, I'm doing this wisdom tooth extraction, there's more likely going to be complications afterwards?
Actually, well, yes, just because of like the natural level of bacteria in someone that has advanced perio disease that's in their mouth, they're more
Yeah. I
likely
didn't know if people
to
were just
heal with
so young
infection.
they heal no matter what.
Well, you'd be
Yeah.
surprised though, because if you leave the follicle on the distal of that second molar, that's likely what's creating your perio defects. Because then you have all of your
Gotcha.
follicular tissue that's sitting on the distal of that second molar. So when you're healing, that is obviously going to have delayed healing. So it's just really important to curette the distal of that second molar very well. And then the second way that I address that soft tissue attachment is with PRF. I put PRF in all of my third molar, lower third molar sites, and most of my extraction sites, because not only does the PRF help regenerate
That's
the bone.
platelet-rich fibrin.
Yes, thank you.
Blood
But
concentrate. Yeah.
actually,
Drawing blood. Yeah. Spinning around.
there's actually a paper that actually written by periodontists that evaluated the distal molar soft tissue attachment levels after third molar surgery with APRF, LPRF, and with nothing. And LPRF actually showed specifically better soft tissue attachment to the distal of the second molar than APRF or no PRF at all.
Wow. Okay. Gotcha. Cool. So
Yeah.
okay. So leave no follicle behind. Like
Yes.
take it out. Take it out.
Yes.
Because I've debated. I'm like, does this need to be here? But it doesn't. It does not need to be there. All of it out.
Nope. It'll create a
Gotcha.
cyst. It'll create
Yeah.
poor soft tissue attachment.
And then I
And
then I have to fix it. So I'm leaving
yes,
problems for
exactly.
myself.
Yes. And honestly, I don't really granulate the apex a lot in the third molar site because a lot of times you are very close to that nerve. And so
Okay.
irrigation should take out most everything. I mean, when you see most of your tissue defects with third molar impactions, it's usually always around the crown. There's very rarely
Right.
periapical pathology in third molars. It's usually coronal pathology.
All right. Suturing. Simple chromic 3O.
My methods are research supported. So there's
Yeah.
also a very classic timepiece article that talks about different suturing methods. So in European countries, they actually use silk sutures. They remove them for a little bit more fast-paced society. Most patients don't want to come back for a post-op
More.
unless they absolutely have to. So my
Yeah.
personal preference is dissolvable sutures. I use a 27-inch 3O chromic because I hand tie. I don't instrument tie in my third molars, and I do a single stitch in the distal of the second molar. If you had to reflect a significant amount and you have a very large opening, I might do like a figure eight, but you really just want to create
Gotcha. I
like
mean, that's
a
equivalent to like two
closure.
stitches in.
Yeah,
Gotcha.
you want to create closure on the distal of that second molar, but you also want to create a naturally cleansing area in case the patient does have bleeding or they do get food stuck in there, because you don't want a postoperative hematoma to be closed. You want it to be able to drain.
Right. It's
Otherwise, you can
antithesis
create
of what
swelling.
most people would think is like, oh, close it off so nothing get. But if something gets stuck, you need an exit point.
Exactly. And so
Um,
actually that was supported by the literature. It was a single stitch distal to the second molar to promote soft tissue closure behind the second molar, but to allow for a cleansable area.
See, that was a hard, like philosophical thing for me to ingest. The less sutures in this area is actually better.
I know.
And that's actually why I think I kind of agree that's the best spot for a 3O, like chromic or a thicker based suture, so that you can apply that pressure to one suture, one good
Yes. One
tacked
good
in
suture.
suture. Yeah.
Yes.
One good suture. I mean, have you tried anything else besides chromic? Have you tried the silk?
No, I
No. Yeah.
don't like anything that has to be removable. I like dissolvable
Gotcha.
sutures. You can't trust anyone. You never know if they're coming back, and then the stitch ends up in there. They end up with osteo, and their jaw breaks because the osteo eats all the way through the third
Woo,
molar
yeah,
cycle, the
which
base of
we're
the
going to go
mandible.
into our second part is when we start
Yes.
talking about complications. So we're going to take a break here at this episode. Again, thank you guys for listening. Thank you, Dr. V, for hanging out with us.
It's
We
my
will do
pleasure.
another, like I said, more follow-up episodes talking about Wizzies and deep diving on wisdom teeth. The best way to support us, follow, like, comment, share with your friends. We do this for the love of dentistry, for the brain of dentistry. Thank you again. Take care, everyone. Bye.
Bye bye.